Welcome to the second talk, which is related to the use of the Silk Vista baby for aneurysm treatment arising, or for aneurysms arising from small cerebral vessels. So we have used the Silk Vista baby in a number of patients already, and we made very good experience with it. So as an introduction, we can say that the endovascular treatment of cerebral aneurysms has experienced significant improvements in the last decade. And most importantly, the introduction of flow diverting technology has driven the strategy away from intra-aneurysmal manipulations and allows a more functional treatment and reconstruction of the affected parent artery. So the densely woven mesh of the flow diverter or flow disruptor is implanted into the parent vessel and covers the aneurysmal orifice. And then immediately after implantation, aneurysmal influx and outflow are reduced significantly. This promotes progressive intra-aneurysmal thrombosis and provides a scaffold for the growth of a new intima along the neck plane or the parent artery aneurysm interface. So here you can see the mode of action of flow diverting technology. We have an example of a peripheral MCA aneurysm of the right-hand side. Here you can see the initial 3D imaging. This is an M3 branch with a twin aneurysm arising from the bifurcation. Here you can see the first aneurysm. This is the second aneurysm. Here we have the corresponding 2D imaging of the MCA and the vector-based velocity imaging. So red indicates that there is a significant and fast flow within the aneurysm. We used Silk Vista baby 2.25 by 15 for implantation, and this is the vector-based imaging directly after implantation. You can see that the flow is reduced significantly as indicated by the blue color. There's only very little red remaining. And at the follow-up 3 months after implantation, you can see that the larger portion of the aneurysm is already completely occluded and that there is like a local angiomatosis to compensate the occlusion. The patient was asymptomatic the whole time. And also the smaller inferior portion of the aneurysm is already shrunken in size. We published our first results with the Silk Vista baby 2019 in JNIS, and we also, this is what I'm talking about today, published the follow-up results quite recently in Frontiers in Neurology. So the first generation flow diverters like the Silk or the Pipeline were actually designed and indicated for aneurysms arising from the proximal ICA, such as the petrous to the clinoid segment. Novel flow diverters have been developed with lower profiles and can be delivered, for example, via 0.021 microcatheters or even via the 165 microcatheter, so such as the Silk Vista baby. In our experience, being able to use a very small microcatheter for implantation of flow diverters significantly enhances the treatment of small caliber vessels, because the probation of those vessels can be very problematic at times. But clinical evidence regarding the safety and feasibility of flow diversion for small peripheral segments is scarce, and therefore we reviewed our experience between June 2018 and December 2019, focusing on efficacy and adverse events. So this is the publication on the Silk Vista baby follow-up results in our center. In a total, we had 44 patients, 31 of them were female, 13 were male. We had 47 aneurysms. 21 had primary flow diversion, 22 were treated with plug-in pipe. So we had a first attempt of coiling, and then we used the Silk Vista baby for the second treatment. In the 47 aneurysms, we used 51 stents. So 36 cases were done with a single Silk Vista baby. 6 cases required 2 overlapping Silk Vista babies. 1 required 3. And there was one case which we did. We used one silk Vista baby in the contralateral A1, A2, and we used two overlapping in the ipsilateral A1, A2 to isolate the ACOM A. So here you can see the distribution of silk Vista babies at the different locations. So here we have 5 cases of vertebral artery pica aneurysms. We had 2 basilar aneurysms. We had 9 ICA aneurysms. We had a large majority of 18 ACOM A aneurysms, 4 pericallosal aneurysms, and 5 MCA aneurysms. In this cohort, we of course used antiplatelet medication. 42 of the patients had our standard dual antiplatelet regimen consisting of 500 ASA and 180 Brilic orally 24 hours prior treatment. And then we use 100 milligram of ASA and 2 times 19 milligram Brilic in the morning and in the evening for 1 year. One patient already had ASA and clopidogrel, which was continued because it was working nicely. And one patient was treated with 2 times 200 milligram ASA only in the setting of acute SAH. So talking about adverse events, we had a couple of technical events. And 2 times we had an immediate shortening, which was related to undersizing in retrospect. We had 2 times immediate shortening due to the tortuosity of the parent artery. And we had 1 delayed shortening at the first follow-up, requiring an additional second flow diverting stent. So overall, we had a couple of clinical events. We had early and delayed clinical events. So in total, we had 3 early clinical manifestations. There was 1 peri-interventional occlusion of a covered MCA branch that was resolved nicely with integralin. As I have shown you in the first presentation, we had 1 case of in-stent thrombosis 5 hours after the procedure, which was also resolved with integralin without any remaining deficits. And we had 1 partial MCA and watershed infarction ipsilateral to a treated A1, A2 aneurysm, which was related to a very long intervention with a poorly controlled blood pressure. So the patient was quite hypotensive, but we didn't notice that at the time, which was very unfortunate. We only recognized it afterwards, but there was no communication during the intervention in this context. We also had a couple of delayed clinical events. So we had 1 death in context of acute SAH due to a rupture dissecting vertebral artery aneurysm extending into the basilar artery. We had 2 delayed vasospasms 4 to 6 weeks after implantation, which was treated with oral nimidipine. The patient recovered well from the delayed vasospasm. We had 1 partial ACA infarction after crossover stenting. So the silk Vista baby was implanted from the left A1 into the right A2 segment as a plug and pipe strategy after SAH. We had 1 partial stent occlusion at distal M1 with transient impairment. I'm going to show you the case in a couple of minutes. And we had a progressive mass effect of a partially thrombosed inflammatory MCA aneurysm with transient impairment, which I will also show you in a couple of minutes. So here is the first case I want to show you. We have a patient with this large MCA aneurysm at the MCA bifurcation of the left-hand side. There's also an incidental M1 aneurysm, which is shown here in the 3D imaging, which you can also appreciate in the conventional 2D images. So the patient presented with facial hemiparesis and fluctuating aphasia 3 days post-procedure. And interestingly, there were already significant leptomeningeal collaterals after the initial coil occlusion. So prior flow diversion, you can see that there are these collaterals. Post-implantation of the flow diverting stent, you can see that the aneurysm is opacified less directly after implantation. This is the implanted Silk Vista baby, so from the superior trunk of the MCA into the M1. And as I said, 3 days post-procedure, you can see that the distal M1 is no longer opacified anterogradely, although the proximal M1 is opacified regularly. And if you compare the DSA injection to the raw image, you can see that obviously the first half of the stent is still perfused anterogradely, whereas the second half, or the portion of the stent which is implanted into the M2 segment, is no longer opacified in this way. So we have a case of conflict flow after SAH. So the patient had suffered from significant vasospasm after SAH and developed very strong, interesting collaterals. And after implantation, the hemodynamic equilibrium obviously had changed and caused the retrograde perfusion of the distal MCA territory corresponding to the situation in acute vasospasm. So as I said, we have this ruptural MCA aneurysm, which was treated with coiling. We have the development of strong ACA, MCA collaterals. Then we have this situation prior Silk Vista baby implantation. We have a nice effect after Silk Vista baby implantation, and then a couple of days after implantation, the hemodynamic equilibrium obviously changed, and the patient was suffering from the aforementioned symptoms. But the distal M1 occlusion was completely collateralized by the already developed collaterals. So I'm going to show you the second case. In this case, we had a non-ruptured, partially thrombosed MCA aneurysm in a young female patient presenting with stroke symptoms. So she had an acute hemiparesis with aphasia, and the aneurysm actually had a progressive mass effect after treatment. So here we have the MRI in the acute setting. Patient was transferred to MRI because she presented with stroke symptoms and was very young. Then we have the DSA prior intervention showing the MCA aneurysm, which is partially thrombosed. Then we did flow diversion plus protective coiling, as the aneurysm had grown significantly within a very short time. So we decided for anti-inflammatory treatment in this context. So if you compare the images directly after implantation and that at the early follow-up after worsening of symptoms, you can see that the shape of the coil package has changed significantly, which was related to the inflammatory effect of the aneurysm. Then 5 days after inflammatory treatment, after anti-inflammatory treatment, the symptoms had resolved completely. And here you can see a very nice effect at the second follow-up already. So the aneurysm has shrunken significantly, and 3 months post-intervention, the reconstruction of the MCA is almost complete. The last case that I'm going to show you is the case of a distant ACA aneurysm at the origin of the Kalosa marginal artery in a patient with 3 further aneurysms and history of prior SAH. So here we have the distal ACA aneurysm in 3D imaging and the corresponding 2D image. The aneurysm was 2 by 3 millimeters in size, and we treated it because the patient had already experienced SAH. So in summary, we have a very high rate of early occlusion after 3 months. I'm using the O'Kelly-Marotta scale to show the results. So 28 aneurysms, almost 62%, were completely or almost completely occluded after treatment. 8 aneurysms, or 18%, had significantly shrunken in size and delayed perfusion. We had 6 aneurysms that remained at the same size but had a delayed perfusion, and we had 3 aneurysms corresponding to 7%, which were unchanged after 3 months. Then if we look after 8 months, we can see that the proportion of completely occluded aneurysms increased a lot. So we have 76% of aneurysms already sufficiently treated. We have 11% with an OKM-B stage, so decreased in size and delayed perfusion. We have 11% or 5 aneurysms that remained stable in terms of size, but had a delayed perfusion. And we only had 2% of the aneurysms unchanged after 8 months. So in summary, we have 98% of a significant treatment success already after 8 months when using the Vista baby. So in conclusion, we have intermediate and long-term outcomes after Vista baby still lacking, as the device received its CE mark only in 2018. But in general, the occlusion rates are at least comparable to other conventional flow diverters in context of sidewall aneurysms in proximal locations, which range between 73 and 89%. So we can compare those results to the distal locations. In context of bifurcation aneurysms, the occlusion rates have been reported of 82% after a median of 13 months by Michelozzi et al. Considering our results in this regard, the Vista baby treatment is at least equally effective, and this has to be discussed further because our dual antiplatelet regimen differs from other studies significantly and may actually prolong aneurysm occlusion. Most studies use 6 months of DAPT, whereas we use 12 months in terms of safety. And the other studies mostly use ASA plus clopidogrel, whereas we use ASA plus ticagrelor. And as it is known and published, ticagrelor is much more potent compared to clopidogrel. So the results after Vista baby treatment may be even superior if you use ASA plus clopidogrel instead of our regimen. So in general, we use ticagrelor because there are no significant cases of ticagrelor resistance, whereas clopidogrel resistance has been reported in up to almost 40%, depending on the different populations. So in general, in challenging anatomies, the implantability of the Vista baby via a 17 microcatheter significantly outperforms other devices which use or require a 21 microcatheter. However, device shortening occurred in 11% of all cases. So it's important to calculate that the Vista baby may shorten after implantation or during implantation. And especially if the proximal landing zone equals the nominal diameter of the device or is even larger, a proximal shortening of 50% must be expected if only half of the stent is already implanted. So it's very important to carefully select the implant prior treatment. In terms of the adverse events, we have 11% of TIAs, and we have 4.5% of manifest strokes. So one has to say that we have a couple of difficult cases, among them cases after SAH and establishment of significant conflicting collateral flow. All of those cases were sequels to focal hypoperfusion of brain tissue after flow diverter implantation. And in our experience, the risk for such events is increased if the patients had episodes of SAH and vasospasm and the development of peripheral collateral pathways that alter the hemodynamic equilibrium. especially when the Silk Vista baby is implanted in an inferior MCA branch, conflicting flow via anterior cerebral, middle cerebral artery collaterals further restricts perfusion of the border zone and the peripheral frontal MCA and may cause neurological deficits. So it's important to evaluate the hemodynamic situation at hand prior flow diverter implantation. But in general, the Silk Vista baby is safe and effective for treatment of peripheral segments, including bifurcations. Special attention must be applied to the individual hemodynamic situation, especially when treating bifurcation aneurysms of the MCA. And in those scenarios, the individual collateral status, the size, and the territory of the M2 branches must be considered. Also, the potential effect of inevitably covered non-aneurysmal side branches must be evaluated. So sometimes you have to cover branches that are not altered, but they are very close to the aneurysm. And it's important to see if they are relevant and if there's actually a chance to avoid that. Okay, so I'm done with my presentation. Thank you very much for your attention. And I'm happy to answer any questions that you may have, especially per email, as I am unfortunately not there in person to answer them directly. So thank you very much.